I was just reminded as I was listening to Andrew giving a great presentation about how sophisticated our imaging is now from CT. And it reminded me that some 16 years or so ago, when we started doing this, we didn't have CT, we didn't have any sophisticated planning. We had a transthoracic echo, which invariably gave us an underestimate of the true size of the annulus, because as you've heard, the annulus is oval, and invariably we measured the short axis, I think. So we often undersize the valves. So there is no question that CT scanning is a very fundamental part of our planning for TAVIs in this day and age. But as you've also heard from that last presentation, it typically uses between 10 and 100 mils of contrast. So the question is, what do we do when someone can't have contrast for one reason or another? Is there a way of still doing the procedure? So I thought I'd use a single case to illustrate this and to also illustrate some of the things that have been discussed this morning. So this was a lady we treated recently, 58-year-old woman from country New South Wales. She had a number of comorbidities, in particular type 1 diabetes, which she had had for more than 40 years. Used an insulin pump. She had amyloid that was biopsy proven in her kidneys and in her heart, but that had been reasonably stable over the last numbers of years. And she developed end-stage renal failure and had been treating that with peritoneal dialysis for about 3 years. She had had some years ago a CTCA that showed mild coronary disease. So the problem now is that she has clearly severe aortic valve stenosis. She has a bicuspid aortic valve, severe left ventricular hypertrophy, peak gradient of 97, a mean gradient of 60, valve area of 0.9, and on her resting ECG, she had bifascicular block. Now, we brought her into hospital, and I had our structural heart coordinator had everything lined up for a very efficient admission, as we try to do for the rural patients. Everything lined up to go, a quick coronary angiogram, a CT, and followed all within 48 hours with a TAVI procedure. And that was fine until I sat down and talked to her. I had assumed she's in end-stage renal failure, contrast isn't an issue. But as I talked to her, it was pretty apparent that it was still a big issue for her. So she actually lived outside town in the country on peritoneal dialysis and did not want to be on hemodialysis. That was going to be a very big factor for her. And she still made a lot of urine. She still made a litre a day of urine and was very protective of what little residual renal function she had. So we had a lot of things to discuss. What would we do? How do we prevent her losing that final little bit of renal function? We know that people with renal failure have a low durability for any bioprosthesis. So whether it's surgical or TAVI, there's a high probability that it will only last a matter of, we've seen some of these last only 3 or 4 years in the renal failure population. So trying to decide what to do, should she have a metal valve, but then she didn't want to have anticoagulants. What is her prognosis really with amyloid and with type 1 diabetes for so long? And what would we do if she came back in 5 years with a degenerative bioprosthesis? So all of this really was room for a lot of discussion. These are her transthoracic echo. She had, or TOE actually, she had severe left ventricular hypertrophy. And I did take the opportunity of taking some coronary shots because I thought that might just help understand what her vascular tree really was like. So we used probably less than 10 mils of diluted contrast just to get some selective angiographic shots, which showed she had really only very mild coronary disease. So the question then is, what are we going to do? Are we going to commit her to surgery? We're going to try to do a TAVI procedure. It's a bicuspid valve. She's got bifascicular block. There are lots of possible treatments. We can either start with a TAVI and then if she comes back in 5 years, put a valve in that, or do we start with surgery and then put a TAVI valve in that? Anyway, ultimately the consensus of the group was that we're not really likely to be having to do 3 procedures in this lady. If we could get 2 procedures, maybe 10 years outlook would be an extremely good outlook for this lady. So ultimately, after discussion with her, we elected to go with a TAVI procedure. So then the question is, how do we do that without exposing her kidneys to risk? Can we do it without any contrast? And the answer is yes, we can, as long as you have some pretty sophisticated echo. If you start with just a simple transesophageal echo, 3D images, there is a great deal of observer variability in the measurements you get. We actually got our fellow and our anaesthetist to all measure give us an estimate of the annular dimensions on the transesophageal echo. But it wasn't until we got Mayo Namasavayam, who's going to speak later today, who is our interventional echo expert, to do 3D multiplanar reconstruction to get very consistent numbers. And he did this multiple times and got an annular perimeter of between 76 and 79 millimeters consistently. He was able to measure the heights of the coronary arteries reliably. He was able to get the coronary sinuses. And based on those measurements, we were fairly confident that we knew what size at least we could treat. What about access? Well, we had to think about access. We used on-table ultrasound of femoral arteries and iliofemorals, and they were pretty healthy and suitable for femoral access. So then the question is, how do we get our landmarks? This valve was reasonably calcified, but not completely. If you look on the left-sided image, you can see that there are two little dots in the non-coronary cusp. So this is our pigtail. So we could be confident that the pigtail was in the right cusp, the right depth, and based on that, we could then deploy our valve. Now, again, remembering we had bifascicular block. If we were too low, then the risk would be of needing a pacemaker, which we were pretty keen to avoid if we could. Using the toe images, we're able to get the depth confidently, I think, and ultimately to deploy the valve in a good position. And fortunately, there was no change in her conduction. She had no conduction block at all. We didn't use any contrast at all for this procedure. Her peak gradient the following day by echo was about 10 millimeters of mercury. There's no AR, and she was discharged home. So I show this really just by way of illustration that there is no question that the best way for us to plan these procedures is with CT imaging. It gives us very accurate measures. You've seen all the measurements that are made, the access planning that we can do. But in selected cases, when there is a good reason not to use contrast, it is possible as long as you understand the inherent errors and can do the necessary viewing to avoid those errors. So thank you. I'll leave you at that.